Hello, my dear friends of Dental XP. This is Dr. De La Rosa from Mexico, and today I would like to welcome you to this presentation that we have titled The Evolution of Site Management for Implant Placement. And it is a great honor for me to introduce you to our new member of the team, Dental XP Mexico, my good friend, Dr. Angel Rodriguez. Angel was a former student of mine when I used to teach in dental school some years ago. And then he went to Boston and pursued his training in periodontics. And he has just returned to Mexico and joined our office here. And we are now working together. Angel, it is a great pleasure for us to have you here and to prepare this presentation of what we have seen through these years together.
Thank you so much, Dr. De La Rosa, for this nice introduction. It is an honor and a privilege to be here with you. I would like to thank you and the Dental XP committee for this invitation, and I hope this presentation will be of benefit to the audience and most importantly, to our patients.
You're welcome. I really think that the join of forces and of minds and working together is certainly a great chance for us to grow and for our patients to be receiving a much complete treatment and care. I think I'm really lucky to have you here, and I thought that there's no better scenario than bring you to the Dental XP family, with which I have learned a lot in the last years and a lot of friends, and we have shared a lot of things. So welcome, and let's start our presentation. And what we try to join and reunite in this presentation is talk about what we have seen through the years have been evolving on this subject, which is very popular today, which is the management of implant placement after an extraction. And we have seen that there's been several techniques that have been suggested to maintain an adequate volume of tissue for an acceptable implant placement, and as well an aesthetic outcome after the extraction. And we have gone from techniques such as nothing, doing the extraction as atraumatic as possible, to go to the socket grafting, when we do the extraction and we place a graft in the socket, wait for it to heal and then go back and then either place an implant or go for a bridge. Mostly we tend to go for the implant. To the other option of doing a bone block graft plus the implant placement at the same time. Then we also went and started to work on the immediate implant placement plus socket grafting plus soft tissue grafting, because there was a time where we were concerned about the soft tissue. We understood that the implant was depending on the bone structures, but then we came into the aesthetic era where we now are very critical of having the soft tissue accompany the hard tissue. And that's when we started doing immediate implant placement plus socket grafting plus soft tissue grafting. Then we came to the understanding also that, well, sometimes it is important to have a provisional restoration, and this provisional restoration might help the outcome of the implant as well as the outcome of the entire scenario. There was some time in the past where we did some implant placement plus GVR. There was a time where we were doing lots of guided bone regeneration with membranes. We started with non-resorbable membranes. I remember those good old days with the Gore-Tex membranes. I was in my perio-grad program. We were placing membranes all over. And then we went to the resorbable membranes, and then we understood that there were many other new options that we could apply, as well as the immediate implant placement by itself. There's also a group that is doing that, just putting the implant by itself, no bone graft, no soft tissue grafting, and it's also something that is important to consider.
So let's begin with the most simple approach that we can start with, which is doing nothing or the natural healing. This is usually the point of reference to compare other techniques, and it's quite important for us to know what will be their effect on patients when we do such a thing, the natural healing. So we have a clinical case which arrived to me during my residency. As you can see clinically, we have triangular shaped teeth. We have a gingiva from scallop to high scallop, a lateral incisor which was fractured, and a fistula already established at the level of the mucogingival junction. The patient complaint was the missing tooth, and the patient would like to restore it. Already a difficult case because it's the anterior sexton, it is the aesthetic area. Radiographically, we can notice that the tooth has been endodontically treated and we have a lesion in the apex. So we decided to extract the tooth to later place an implant. During extraction, for several reasons, we decided to do nothing. The main one, of course, was the infection. And 4 months after healing, you can see that the site has healed nice. However, we already see the loss of the papilla. We already lost like a 50% of the papilla. The remaining papilla is thanks to the neighboring teeth, which are still there. Some people may argue or debate that this could have been prevented by different means. I will defer on that. I think this is a scenario that we are constantly seeing in our practices and in our patients, that regardless of what you do, you're going to have some loss of the tissue. That's why several techniques keep appearing in order to prevent this. This is something that is able to be managed afterwards with a soft tissue graft and have an acceptable outcome. So what can we expect after extraction in the socket? So the phases of healing that are going to happen are basically 4. You have the first one, which is the clot formation, which usually take about 0 to 12 hours. You have the incoming of platelets to stabilize and form the coagulum. Then you have an immune response, the granulation tissue formation or matrix formation, where you have the incoming of immune cells like neutrophils, monocytes, the first line of defense, just to check that everything is fine, leaving this matrix, which is gonna serve for the undifferentiated cells to become osteoblasts to later on start forming the bone. Then you have bone modeling, which is the formation of bone now, which usually happen at the end of the first week, and it goes on up to the 8th week. So now you have the deposit of immature bone, which later on is going to be remodeled by osteoclasts. And then you have the bone remodeling. The bone remodeling, which osteoclasts come and take over this immature bone and start giving it the architecture that we would like to have in a healthy bone, talking about Harvestian system, Waldman canals, and that usually happen by the 6th or 8th week and keeps going through the lifetime. Remember that all these phases have its own time, and you need to let them have that time in order to have a good outcome at the end in the long term. Because the bone will need to have the properties to withstand mechanical forces, and in our case, when we replace an implant to withstand occlusal forces. So different cells come in each phase, and in this era of growth factors or biomodifiers that they claim to enhance or accelerate healing, it is debatable the use of these products. For example, we have the use of Emdogain, which at the beginning was proposed to be used in soft tissue graft. Later on, the use was extended to bone graft. Nowadays, if you're having coffee, you're using Emdogain. If you are depressed, you're using Emdogain. I mean, all these biomodifiers, growth factors are promising, but I think shouldn't be used yet. Because there are still many questions to be asked about these growth factors at a cellular level. Having said this, definitely they are the future, and we should be grateful, very grateful to the companies, because without them, we couldn't have biomaterials to put in people's mouth. Nonetheless, the use and value of these biomaterials in the clinic should be based in reliable experimentation, not by marketing or companies before going into the market, because of the possible risks that they may carry, like causing cancer in the case of growth factors. So we can expect a collapse of the tissues about 30 to 50% in an horizontal manner and a vertical loss of 1 to 2 millimeters after extraction. During implant placement, as you can see here, we raised the flap, we noticed that we had enough bone, we placed the implant in a proper position, and then we suture it back. Here I'm showing you again the deficiency of the ridge contour after extraction, that is constantly happening in any other technique. That is something that we are still not able to manage or to prevent after extraction. it can be managed afterward with other techniques. But so far, some kind of collapse and contraction we are still experiencing. But this is a nice case where you can see what your body is capable of when doing nothing. Because you need to have always this question in your mind. What will happen if I do nothing? Quite often, my friends, is nothing. So now, another technique that was proposed was the socket grafting. Socket grafting consists basically of extracting the tooth, placing a graft into the socket, and then suturing. Whether you put a cola plug or a membrane up top, the concept was interesting. We have a case here where the second molar was not restorable. We extracted, then we placed some FDBA and cola plug on top. Here, we use the socket grafting again, but now plus membrane. We have a canine that was extracted, the socket was filled with FDBA, and then the membrane put on top. This was usually used in a cone-technique way. But let's analyze what is going to happen in the socket after you place any biomaterial into it. We have here a case or a paper from Santos where he used three different biomaterials and natural healing. The natural healing is the first one, is the picture A. The picture B, they use hydroxyapatite. The picture C, we have bovine bone. And the picture D, we have bioactive glass. These samples were taken at the 4th week. As we can see, or in the natural healing, we have a nice configuration of the bone, immature bone already in the socket. In the hydroxyapatite, bioactive glass, and bovine bone, we see the particles there in different configurations around them. By the 8th week, in the natural healing, we are seeing already a corticalization of this immature bone. In the other three pictures, the other three biomaterial, we see different configurations and sometimes some infiltration. By the 28 weeks, we have no reason to go in depth into the natural healing. We see a nice result. So far, the best healing that we can have. And in the other images, we keep seeing the particles of the bone grafts still present and with different configurations with the surrounding tissues. Now, the issue doesn't come with the series of images that I just showed you. The issue comes with the interpretation of them. And before sharing my interpretation, I will mention a paper from Albrechtson demonstrating the evidence in biopsies taken from humans where they have previously undergone sinus lifts and with the particles of bovine bone still there without being resorbed after 11 years. Now, we have to ask the question, if we place these biomaterials in humans, will they eventually become functional bone, or is it going to be camouflage? If we have the particles sitting there, we'll definitely augment the volume of the tissue due to the space that is occupying. However, we have to remember that we're looking for a functional bone tissue to be able to withstand mechanical and occlusal forces. This is why natural healing is the best approach to have functional bone and is the best from a biological and histological point of view according to this paper. I won't give up on what your body is capable of doing if you let it heal by itself. However, definitely 4 to 6 months after extraction during reevaluation, if you don't have bone volume to place an implant in a correct prosthetic position, you should bone graft first. And here's where I will suggest you to use autogenous bone grafts that remain the gold standard when it comes to restoring adequate bone dimension for an implant placement. And if you're looking for a camouflage, I will encourage you to go for a soft tissue graft, which is much safer from a clinical standpoint of view. So the conclusion of this paper was that all the biomaterials retarded the extraction socket, and they show similar histological characteristics in them. So now let's see clinically the value of them. This is a nice review by Araujo published in Periodontology 2000, which the editor-in-chief is Dr. Jürgen Slotz, and I would like to take a moment to acknowledge his work. He's one of the few that remains keeping the scientific method as one of the very important for our field. Recently, we see a lot of attention of residents and people to cameras and lens, and sometimes forgetting the value of the science and the scientific method. And I think these people should be really, really acknowledged to keep that essence of science in our field. So going back to this review by Araujo, we can see in the first row the paper from Brownfield and Welma in 2012, where you have 17 patients, 20 sockets. They compare FDBA versus natural healing. The method of evaluation was clinical, histologic, radiographic, and tomographic. They follow up to 12 weeks, and the change in the reach width was in the test group about 1 millimeter and in the control about 1.3. The change in the height in the test group was 0.8 and in the control 1.2. No difference were found between these groups. In the following article by Tolue, we have 21 patients and 31 sockets. They compare calcium sulfate versus FDBA, and they had histological and clinical analysis. They follow up to 3 months, and similar results were found. No difference between groups. Kim et al. In 2011 had 20 patients, 20 sockets, compared xenograph versus extraction alone, and they concluded, or the outcome was, that the resorption in the reach width was in the test group about 14% and in the control about 20%. Golami had 12 patients, 28 sockets, and they compared synthetic biomaterial versus bovine bone, again showing no difference between the groups. Once again, an interesting concept with the idea of preserving the rich contour and the tissues after extraction, but failing in doing so.
So when we come to the option of extraction and immediate implant, we should remember that the original idea of this approach was the belief that by doing an extraction and putting an immediate implant, if we had a wide implant, then we will have a less distance between the implant and the alveolus wall, and the idea was that this will prevent the resorption of the process of the ridge process. So on this case, we extracted a premolar. A clean extraction was performed. You can see that the osseous walls of the socket are almost intact. The implant was placed towards the palatal root, which is normally the way to go. No bone graft was placed, and the flap was sutured covering the implant. Following the idea of this concept that having an immediate implant placed would prevent the collapse of the ridge. Through the years, we have seen on the literature interesting information like this paper by Botticelli in 2004, where he reported significant horizontal resorption in both buccal and the palatal bone plates, 56 and 30% respectively, after placing single-unit immediate implants in the upper maxilla. Above 90% of the gaps wider than 2 millimeters were filled by spontaneous healing. Tomasi and his group in 2010 mentioned that the closure of the gap seems to be independent of the original size of the defect. And then a very nice review, Periodontology 2000 by Vignoletti and Sanz and Mariano Sanz in 2014 concluded that marked morphological changes of the alveolar ridge will occur independently of the implant installation, and by thus demonstrating that post-extraction bone loss is an inevitable biological process in both clinical and experimental studies. So by these we can understand, and from what we are reading and what we are seeing in the clinic, that the simple idea of placing an implant immediately after the extraction will not by itself prevent the collapse of the bone loss. So then we went to the option of, okay, let's do an immediate extraction, and now let's put the immediate implant placement. But what about if we add something extra like GVR? And what is GVR? GVR is a term coined by Danny Boozer in the early 90s, and it refers to the use of a membrane to aid the healing, to guide the healing towards the new bone formation. And in this option, what we do is we do an extraction of a tooth, an atraumatic extraction, and then we place an implant and try to do a GVR at the same time. So we do the implant placement. In this case, an implant was placed plus a bone graft plus a membrane. In this case, a resorbable type of membrane was used. Sometimes it used to be that we used the non-resorbable membrane. Now it is more common to use a resorbable membrane. So the membrane is placed with the graft, flap is sutured with the idea of preventing the collapse of the ridge. But look what happened in 2 weeks and then in 3 months. We still see a collapse of the ridge at a certain point. So when we see the literature on the immediate implant placement plus GVR, we can see the paper by Chen in 2007 when he found no significant difference in the amount of gap fill, both horizontally and vertically, although the grafted sides were able to preserve significantly better the horizontal contour of the buccal crest. With a mean follow-up of 2 years, 25% in the test size versus 48% reduction in the control sides. So the extent of the horizontal resorption may be reduced to 25% of the original buccal dimension with the use of anorganic bone grafts and our barrier membrane. So we're reducing the extent of the resorption, but we're still seeing resorption. So we have not succeeded 100% in reducing or eliminating the contraction of the alveolus ridge. Now, what if we add an extra factor to the equation? What if we treat a case and we do immediate implant placement after extractions, we put a bone graft, but now we add a provisional restoration? Well, this was a case we treated 10 years ago, more or less, and a patient came to our office with the central incisor, maxillary central incisor fracture. Patient was in pain and wanted to have the teeth extracted and replaced with implants. When we see the pro-index of this case, we see a very typical scenario on the pro-index reading, and we see a shallow depths on neighboring teeth. And on the two central incisors, we see 339944, which is clinical image of a fractured tooth. We can see a abscess formation as well. And it's a very straightforward case in which we know we need to go in and do an atraumatic extraction of both central incisors, which we perform. And the extractions were done without raising a flap, which is also a very important factor to consider. And two implants were placed. The two implants were placed following a surgical guide. And then we placed a bone graft, in this case by us, was placed in the gap to fill the gap. And we added the factor of a provisional restoration. So for this case, we had the two implants, a bone graft by us, and then we added a screw-retained provisional restoration with the idea of having a seal for our bone graft with the provisional restoration that will allow it to heal a little more stable and have a better result. Interesting to note in this case that we found a very nice result. We can see the initial picture, the immediate provisional plus implants, and then the 2-year results. If you can see the 2-year results, we can see a very nice result. We can see we have been able to maintain the papillary height through these two years, and we have seen these on the years following that we have followed the patient on a maintenance care. So by adding the provisional restoration, we now have a better result in terms of reduction of the width, but we still see that reduction, but it's minor or less than what we saw with other approaches. Now, one of the groups that certainly have given us a lot of information in this area has been the group of Dr. Salama and his group and Dr. Stephen Shu and his group. These two groups joined in several papers, and they have described extremely well in detail how the behavior of the soft tissues and hard tissues with an immediate implant placement. And one of the nice papers of them was published in the year 2012 when they published the dual zone concept, and this approach involves an atraumatic tooth removal without flap elevation and placing a bone graft into the dual zone, which is tissue zone and bone zone, around an immediate fresh socket anterior implant with an screw retained provisional restoration, which will act as a prosthetic socket seal device. Interesting to note over here was the results and how they explained them and divided them in certain areas that will make us better understand how the tissues will behave on the healing after the implant placement. And they have 4 groups of patients that they treated. The control group consisted of patients where they perform extraction and immediate placement, no bone graft, just healing abutment, and that was it for that group. Then they have the provisional group, in which they did an extraction, immediate implant placement, and they placed a screw retained provisional restoration with no bone graft. Then they had the graft group, which they had extraction, immediate implant placement, and a bone graft with no provisional restoration. And then group 4 was patients where they treated with extraction, immediate implant placement, they placed a bone graft, and then they did a screw retained provisional restoration. And usually the most critical site over here, of course, is the buccal area. And in the buccal area, what they did was they divided the results regarding their distance to the fringe gingival margin. 0 millimeters, which is the gingival margin itself, 1 millimeter apical, 2 millimeters, 3 millimeters, 5 millimeters, 7 millimeters, and 9 millimeters. Usually when you are in the clinical scenario, we have seen that the 3 and the 5 millimeters distance from the fringe gingival margin are usually the areas where we have the most critical response of the different modalities that we are using in treating our patients. Interesting to know here is that when we go to the control group, on the 3 millimeter, we had a reduction of 1.1 millimeter of the width of the ridge. And in the 5 millimeters, we have 1 millimeter reduction. Now, when they added a provisional restoration, that reduction was less. Now we had 0.7 on the 3 millimeter mark and 0.6 on the 5 millimeters. And then when they studied the group where they did immediate implant placement with a bone graft and no provisional restoration, now they reduced that resorption to 0.3 on the 3 millimeter landmark and 0.3 the same on the 5 millimeter landmark. And then finally, when they went to group 4, when they had the graft and the provisional restoration, now they have a reduction of 0.1, which is almost none, and 0 millimeters on the 5 millimeter landmark. So this is very crucial. This no change on the width of the ridge with the immediate implant placement plus bone graft plus provisional restoration is certainly a key point for us to consider when treating this type of cases, because this is certainly the approach that will have the better outcome in terms of reduction of the ridge after we perform the immediate implant placement. So I think these are very important numbers to consider, and these papers certainly give us the pathway to follow on this type of cases, because this is a scientific evidence of what we need to do, what we need to plan to have a much better result on our patients when we do these type of therapies. Now, the other option that comes to our mind, which is natural as a periodontist, is what if we put a gingival graft on top of this equation, on top of having an immediate implant placement, bone graft, and what if we seal this with a graft? And this was published in 1997 by Landsberg, when he termed the socket seal surgery as an alternative to obtain an optimal soft tissue volume in the aesthetic zones with immediate implant placement. Then Stein and Hamaker in 2015 made a variation in the technique using a tunneling approach. The buccal gingiva and interdental papilla are undermined and augmented with the soft tissue grafts. Now, we have treated these type of approach in our clinic, and this is a case in which we had a patient with a fractured central incisor, and we needed to perform an atraumatic extraction with an immediate implant placement. So in this case, we planned the case, and we were going to use the technique published by Jose Carlos Martin da Rosa, in which we're going to bring a tuberosity block graft and place it on the area of the gap, and then we will try to do the soft tissue seal as proposed by Landsberg. The patient was seen in our office. An atraumatic extraction was performed, and then we followed the steps mentioned by Martin da Rosa, where he explains you very in detail how to measure the alveolus, and based on this measure you will decide the diameter of the implant. The implant was placed following a surgical guide. The radar implant was placed, and then we went to the tuberosity, and we brought the block graft from the tuberosity. It was securely placed in the area of the gap, and afterwards the soft tissue graft was placed and sealed this area. And what we saw was interesting enough to see a very nice soft tissue response when we saw the patient initially, and then after several weeks and after several months we had a nice behavior on the healing, but we still saw a little contraction of the ridge with this technique.
One of the advantages that I see from this technique is that we're going to be increasing the thickness of our soft tissues, where we have seen the impact of this thickness on the early bone loss around our implants. The first one showing evidence of this was Dr. Berglund, one of the best students of Professor John Linde. He showed for the first time evidence of the need of a certain minimum width of peri-implant mucosa, and that bone resorption may take place to allow a soft tissue attachment to form to protect osseointegration. Later on, Linkevicius in human performed a series of clinical control studies and confirmed this hypothesis that our body tend to like about 3 to 4 millimeter of thickness around the implant of peri-implant mucosa, and that's something that we should have in mind in advance when you see a thin gingiva. This is something that the early bone loss can be prevented with the use of any soft tissue graft. So the techniques that we have been reviewing involve the use of different biomaterials, and some of them carry the risk of transmission disease, like xenografts and like allograft. This is something that we should not be neglecting on, and we should keep ourselves updated in order to provide safe treatments to our patients and inform them correctly before the use of any of these biomaterials. I'm gonna leave you here these two nice reviews from different groups where they go in depth and review these kind of risks. The following technique that was suggested was immediate implant placement plus block graft. Here we have a case of a premolar which was not restorable. We extracted atraumatically, but clinically we noticed that we had a fenestration, this is something that had to be addressed at the time. So we decided to go for a block graft. The block graft was taken from the palate. We can see there the nice contact of the block graft to the recipient side, which is critical for the survival of our graft. But you have to remember that this bone graft is already dead, so will only serve as a scaffold for the cells to take cover, and more likely the genes that are beneath or are in the recipient zone are going to be expressed and remodel that bone of the receiving zone. Eventually the genotype of the recipient side would be expressed, leaving a similar phenotype on the new bone after remodeling. Here we can see the suture and then the 4 weeks follow-up. And I would like you to notice here that even using a block graft, we have created the basis, the structure to be able to build on top with a soft tissue graft. And we were able to manage a nice thick bone that the block graft is going to allow us to have surrounding our implant, but still we could not prevent the collapse of the ridge. Here, another series of images from this case. We see the fenestration through the gingiva with our probe, Raising the flap, we see the fenestration there, so we decided to go to the palate with a trefine burr. We took the block, we split it, and we stabilized it in the crestal area. Unfortunately, the second block was fractured, so we just placed the chips there and sutured the flap back. We didn't use any membrane of any other biomaterial because we would like to have the blood supply coming from the flap. We have seen that the blood grafts are very capable of preserving the space and preserving the volume without the use of any biomaterials. So going through the literature of blood graft, we have a nice review by Diadona and Nausari in 2001, published in Periodontology 2000, where cancellous transplants may be entirely penetrated by blood vessels in 2 days and completely revascularized within 2 weeks. On the other hand, cortical transplant may take a bit longer, about 6 days, to be invaded for the first time and completely revascularized in 1 to 2 months. This is because they are denser, the cortical part is denser and more compact. However, this is allowed by the microarchitecture of the blood, which the vessels use the Boltzmann canal to revascularize the blocks. Intramembranous autogenous osseous transplants are the gold standard in the restoration of intraoral osseous volume, was the conclusion of this paper. Zerbo in 2013 analyzed also blood graft and concluded that bone blood graft are progressively remodeled into new vital bone within 2.5 to 7 months, because this was the period of time that this article included, and that bone is resorbed and remodeled by osteoclastic activity, followed by bone formation. Usually the average time that we wait after a blood graft is placed is about 4 months. This is one of the advantages of blocks because it has one of the shortest periods of healing time compared to other biomaterials. Peña Rocha Diago in 2013 compared implant placed with blood graft and blood graft and later implant placement, and yield very good result with this technique. Implant survival rate of 90.5% and success rate about 93%. So already a good technique to approach this kind of cases. Glaugman in 2016 showed a series of clinical cases where he went and took blood graft from the palate and showing also nice results, concluding that harvesting an autogenous bone block from the palate is an advantageous, predictable, and reproducible method for augmenting buccal facial defects at implant placement. Chapuis is one of the members of the group of Dr. Boozer in 2016 show evidence of the stability of these blood grafts in the long term, up to 10 years, demonstrating a favorable success rate of 90.1% with minimal blood graft resorption of 7.7%.
So when we evaluate the factors that are influence the outcome of our results, we have, for example, the reasons of the extractions. Of course, when we have a case like Angel showed you at the beginning of this presentation, when we have an infectium process or endoperioral lesion, well, we will, of course, expect to have a bigger destruction and a massive contraction of the soft and hard tissues after we do the extraction. Very different scenarios when we have a tooth that has been fractured and we're going to extract it due to the fracture. The status of the alveolus will be very different on a infected side extraction versus a fracture side extraction. And the status of the alveolus is a very critical factor when we also consider certain teeth and their anatomy and the position of the tooth in the alveolus. Sometimes we have a tooth that has been gone through orthodontic therapy and is on a better position on the osseous envelope, and sometimes we have a tooth that has, for example, had a pathological migration due to periodontal disease, and they go buccally. We also have seen these in a private practice scenario. And those teeth will have, of course, a very thin buccal plate, maybe thinner than what we saw in the papers by Nosari and Mariano Sanz, and when they showed that the mean width was 1 millimeter or less. So the status of the alveolus is something very important. Now, the gingival biotop is something very critical as well, and something that has received more and more attention as the years go by. I would like to share with you a nice conclusion of a systematic review by the group of Switzer and their group in Europe. And when they concluded from a literature seminar systemic review that the available literature, what we have as of today, the association between thin bone and thin gingiva was from medium to low. In other words, this means that even though we tend to think that when we have a thin gingiva, we're going to have a thin bone, that is not always the case. So don't think in your mind that if you have a thin gingiva, you will, by law, have a thin bone. That is not always the scenario. Another of the factors that can influence the outcome, of course, is the number of extractions. It's very different to have a single tooth extraction and implant placement with two nicely and healthy teeth on the sides than to have a 2 or 3 or 4 extractions neighboring teeth. We, of course, will have a stronger reduction and resorption of the hard and soft tissues after having a bigger number of tooth extractions in the neighboring sides. And last but not least, the site of the extraction. If we're talking of the anterior teeth, we're going to have a different behavior of the soft and hard tissues as we will have on the posterior teeth, as well as with the maxilla and mandibular teeth. So what we have understand from all these concepts is that there are different things that can influence the periodontal status of the soft tissues with the thickness and the height. So all these outcomes that we have reviewed are highly influenced by the periodontal tissue status and thickness. So I think it is very important to keep these in mind and keep all these scenarios in mind at the time we decide what technique we're going to use when we treat this type of cases.
So now we have understand that the outcome of many of our procedures are going to be highly influenced by the thickness of our tissues. Authors like Araujo and Wiquesco, when it comes to alveolar bone, have suggested that at least 2 millimeters of presurgical facial bone may be needed for optimal healing of both hard and soft tissue after extraction or implant placement. And I agree on them. I think this is a very important, a critical threshold that we should have in mind when placing an implant or extracting a tooth. However, we should ask the question, what is the prevalence of this thickness in the regular population, in our population, of 2 millimeters? So there are several people which set their mind to analyzing the population and analyzing the thickness of our corticals. We have one of the first paper published by Nausari in 2012, where in this paper they only included maxillary central incisors. They took measurements of the crestal. They took measurement of the buccal cortical at 1 millimeter from the crestal bone, at 2 millimeter from the crestal bone, at 4, 5, up to the 10 millimeters from the crestal bone. They used CBCT. They included only healthy patients that were coming for orthodontic treatment, for their molar extractions, no periodontal disease, healthy people analyzed by CBCTs. And they found occurrences of maxillary facial alveolar bone of greater than 2 millimeters or equal to 2 millimeters of the 202 teeth were on no more than 3% of the root surfaces. The percentage of teeth with facial bone, again greater or equal to 2 millimeters at levels 1, 2, 3, 4, and 5 from the bone crest was 0, 1.5, 2.0, 3.0, and 2.0 respectively. So in 90% of the teeth, a thin facial bone was noted. This study evidenced the prevalence of a thin facial alveolar bone that may be contributed contributing to the risk of facial bone fenestration, dehiscence, and soft tissue recession after immediate implant placement. So far in this population study in Los Angeles, it's telling us that we have a high prevalence of thin facial bone in our dentition. And another paper analyzing the same topic was published by Gazemian in 2012. Now was published in this study was done in Italy, concluding similar results, but now including canine to canine in the maxilla. This present study supports the finding of a predominantly thin facial bone overlying the 6 maxillary anterior teeth. Therefore, it is essential to make informed treatment decisions based on thorough site evaluation before immediate implant placement. So we are seeing now that thin facial bone is being prevalent. Now, this study was done in Italy. Similar studies have been done in Sweden, in Brazil, in Mexico, in Iran, all of them concluding similar results. And I would like to analyze from this table a left lateral incisor. I'm picking this tooth because it's the narrower in diameter of the root. The narrower the diameter of the root is, the greater the bone that is going to be surrounding this tooth. That's why I picked this tooth in it, because it has an interesting finding of this paper. We are seeing here at the distance of 1 millimeter from the bone crest, the mean that was 1.1 millimeters found in the thickness, and a minimum of 0.5 and a maximum of 2 millimeters. Again, we have cases where we have those 2 millimeters, and those are the cases that you would like to treat. And regardless of what you do, you're going to have a nice result. But at 2 millimeters from the crestal bone, we see that the mean increase, the minimum found was 0.5 and the maximum was 3 millimeters. Again, we're doing great. At 3 millimeters, we have the mean increase a bit, 1.59. The minimum was 0.5 and the maximum was 3 millimeters. But here's when it comes interesting. At 4 millimeters from the crest of the bone, we have a mean of 1.48, but a minimum of 0 and a maximum of 3.8. The minimum of 0 is telling us, is making us aware of the presence of fenestrations in this population. Also, other authors have found the presence of dehiscence and fenestrations. Usually the threshold of the division of them is 3 millimeters. So put them both together, the average prevalence of this dehiscence and fenestration is about 30%. And this is something that you should analyze every time you're having an extraction and an immediate implant placement, just to be able to detect this on your patients and prevent any complications. Remember that you need to have 2 millimeters, not just in the crestal area, but all the way to the apex. Those 2 millimeters need to be consistent and need to be even all the way down. If you don't have it and you have a fenestration later on, this again is going to compromise your outcome and your treatment. So the average that this paper found of thickness at 3 millimeters from the bone crest, it's for the right maxillary canine 1.47, for the right lateral incisor was 1.73, for the right maxillary central incisor was 1.45, for the left maxillary incisor was 1.41, for the lateral was 1.59, and for the left canine was 1.6. As you can see, none of them reach an average thickness of 2 millimeters. So we have everything in favor in the population to have a poor result. We don't see that often those 2 millimeters that we would like to have an optimal result. And this is something that we should accept and we should understand, because that's the way we can protect each other and we can have a good treatment plan, communicate with the patients, and have expectation closer to reality. According to the available literature, it seems that we are predetermined to have a thin phenotype. Now remember that the phenotype is influenced by our genotype and environmental factors. Genotypes is the set of genes stored in our DNA, and phenotype, it is the observable characteristics of the organism, we sometimes can change the phenotype with soft tissue grafts or bone grafts, although the long-term data is limited. Maybe one day, with advances in medicine, we will be able to modify or change the phenotype more effectively than today. So now when it comes to single to versus multiple extraction, is also a different scenario. This paper from Alaskar, where they divided three groups, the green group where they extracted a single tooth, the purple group where they extracted two teeth, and the blue group where they extracted three contiguous teeth and analyzed the data by CBCTs. They took cuts at 1 millimeter from the crestal bone, at 2 millimeters, at 3 millimeters, all the way to 6 millimeters. And you can see obviously how when you increase the number of extraction sites, the amount of bone collapse or bone resorption is gonna be greater. So different treatment plans can be proposed when you having a single extraction site to a multiple extraction site. Again, treatment planning is very important to prevent any complication and to give real expectation to our patients. The conclusion was that contiguous teeth extraction caused significantly more alveolar-rich bone loss as compared with when a single tooth was extracted. Now, this slide is giving the value to the complex unit of the periodontium, comprising alveolar bone, cement, periodontal ligament, and gingiva. Their organogenesis and their ectomesenchymal origins are of great importance to investigate more in depth at a cellular and molecular level, because it is what is maintaining the alveolar-rich anatomical features. And after analyzing the results of the review techniques, we have realized that we have had limited results and failed in preserving the rich dimensions after extraction, disrupting this complex. This is why new techniques keep being suggested, and some of them are going back to preserving these tissues in part to bring better and more reliable results. We have a promising techniques with is giving this as the basis for the technique, which is preserving a tooth fragment, but more than that is preserving that periodontium to the buccal area, which is called the socket shield. This is one of the first papers that was published of this technique. Was done by Hurzeler, a very bright periodontist clinician from Germany, where they preserve a tooth fragment and place an implant, concluding that retaining the buccal aspect of the root during implant placement doesn't appear to interfere with osseointegration and may be beneficial in preserving the buccal bone plate after implant placement. After this got published, several other authors start using the same concept with different names, but same concept, preserving the periodontium. Kahn, in 2013, used the concept to preserve the inter-implant papilla, calling it proximal socket shield. This was a case report where you can see an implant was placed previously. Now you have the need for an extraction of a tooth that was there. They preserve the fragment of the tooth interproximally between these implants in order to preserve the papilla. Same concept. Constantinos in 2014 called it the root membrane. This was done in 46 patients, was done in humans, followed them for 5 years. It was a retrospective study showing good results. The only complication that they noticed was the resorption of the apical part of the root membrane, but as you can see here in the image on your right, it was due to the apex lesion that was there. Although it didn't compromise the implant, it didn't compromise the outcome, neither aesthetics, it's just something that they noticed. Baumer in 2015 from the same group of Hurzeler investigated if the socket shield technique can only be used with intact root or also works with a modified shield design, referring or resembling a vertical fracture line. This was done also in animals, giving good results, telling us that when you have cases like this is also a predictable technique to use in our patients, which is a constant or is something that we see sometimes in our patient in a clinical scenario.
In another paper by Gluckman, Howie Gluckman, who is a professor in LXP and dear friend, in 2016, he published a Pontic shield that he named, and he used this for the preservation of the Pontic site development. And he explained this very neatly in this paper, as well as in different LXP presentations. And it's very interesting to note how he can manage the Pontic site with the Pontic shield concept, and by thus maintaining the original dimensions of the alveolus ridge. Guirado in 2016 published the root T-valve technique that consists of placing the implant in the preserved tooth root, which will surround the implant in its entire circumference. And this was in an animal study. And this is interesting because he maintained the socket shield towards the buccal and lingual, as well as interproximal, and by doing so, he will have the implant completely surrounded by the socket shield. Interesting concept as well. Now, we have done this in the clinic, and we have seen very interesting results and promising results with the socket shield technique. This was a patient that had a fractured central incisor, and we performed the socket shield technique on this fractured central incisor. We did a little gingivectomy to aid on her aesthetic appearance. And when we perform the extraction, we did it with the socket shield. We segmented the root. Once we segmented the root, we removed the palatal portion of the root, and then we will now prepare the socket shield to a better dimension. And once we finish the socket shield, we normally leave it on a thin portion of tooth, and we leave the socket shield a millimeter above the crest, the osseous crest, to maintain the periodontal fibers. Afterwards, the implant will be placed. The implants will be placed following a surgical guide. Normally, the implant will be towards the palatal osseous wall, and then we place an osseous coagulum to fill the gap, and we place screw-retained provisional restoration. So a radar implant was placed in a screw-retained provisional restoration, and we can see the image 2 weeks after the surgery very nicely. The soft tissues are maintained. We can see very minor changes with the original scenario. So it is an interesting concept, very nicely performed on anterior segment, and we can also perform it on the posterior segment as well. We have a case here where we have a molar, and we had the molar to be extracted also due to a fracture. So we perform a socket shield on the molar, and here we, after preparing the roots for the socket shield, we have contact with the interradicular bone. And when we had this bone available to start drilling to place the implant, we now use the DENSA system, which is towards the osteodensification concept. And with the help of the DENSA system, we now were able to place the implant immediately. And we finished preparing the socket shield. And in this case in particular, we did not place a bone graft. We only use a collagen sponge to fill the gap, and we place a suture just to maintain the sponge in place. And we can see this image a couple of months after the surgery, a very nice seal of the soft tissues, and we can see the cone beam afterwards. We can see the dimensions are maintained, and when we see in depth, we can see that the image, the clinical image, we can see almost the same scenario of the width of the ridge. We haven't seen any difference. It has been maintained as it was originally. So this is one of the highly important factors of the socket shield technique, I think, and we think that it is certainly a promising technique, and it's certainly one of the best ones we have been able to maintain the results of the therapy as they were before the extraction. So based on the limits of our presentation, we can conclude the following. The alveolar ridge alterations following extractions are inevitable. The techniques proposed to counteract the changes have had limited results or failed to achieve this goal. Understanding of the complex unit of the periodontum will allow us to try to preserve it and further investigate the interactions between them. Certainly, the socket shield technique is a treatment option that is accomplishing the preservation of the ridge contour by conservation of the complex unit, which is the periodontum. In our hands, it was the only technique that gave us promising results in achieving the preservation of the ridge contour so far. Although long-term data is available up till now is limited. So, as we have seen, one of the most challenging aspects in implant dentistry today is the ability to perform an implant placement after a tooth extraction that maintains the characteristics of the soft and hard tissue. And as we have seen, we have witnessed, the science of implantology has evolved to better understand the language of the tissues. And as a result of this evolution, today several techniques have been suggested to maintain an adequate level of soft tissues and an adequate level of hard tissue to place the implants. And as I mentioned previously, the socket shield technique has been the most promising in all these options to maintain the structures. But I think when we analyze this in depth, we are just grasping the potential of biology, and there's a long road still to be walked together, and I think the best is yet to come.
We would like to finish with this picture of a Mayan ruin, a civilization who once showed what humans are capable of doing when they work as a team, contributing with science, philosophy, cosmology, linguistics, and wise men. Also, we would like to take the chance to invite all of my friends in dentistry and all of my scientist friends to work once more as a team to solve these issues and decode the mechanisms underlying these biological processes to be able to help our patients. This presentation is dedicated to Dr. De La Rosa, father and son, Dr. Jorgen Slotz and Dr. Hesam Nausari, men of word and integrity who are very dear to me. I hope this will bring honor to their lives. Thank you so much for your attention from Mexico.